yeah, this platform.
Hello, and welcome to The Naked Truth. I am Jennifer Bleacher. I am one of your hosts this evening, and I am so excited to be here tonight with Patty. Patty, welcome.
Hi, everyone. Thank you so much, Jennifer. It is a sincere treat to have you on tonight with Dr. Katzen. We are so honored to have Dr. Katzen with us again tonight. We are going to be covering the area of the breast and chest, and we've taken a lot of great questions, and we just want to thank everyone who submitted their questions, and we want to thank Dr. Katzen, of course, for his generous offering of his time this evening. He's been in surgery all day, and so we're just really, really thankful to have his input. So,
Sure.
yes, thanks, Dr. Katzen.
Sure, thanks for having me.
Absolutely.
So welcome. We're going to jump right into it because we do have a lot of questions, but if you're watching live and you'd like to submit a question live, please feel free to do that. We have the Q&A up. I also have my Facebook open, so feel free to PM me on Facebook if you're not able to ask a live question. So, Dr. Katzen, because our breast tissue is different than, oh, I'm sorry. Let me say that again. What are the surgeries of the breast area that people typically have following weight loss surgery?
Typically, women undergo what's called a breast lift, where the breast is reestablished back to its original position. So that's the most common procedure. A lot of women also lose fat of the breast, and they need some restoration of the fat. So a lot of women also have augmentation done at the same time as the lift. So typically we do breast lift and augmentation at the same time. There are a small percentage of patients who don't lose a lot of breast tissue and are still left with a lot of breast tissue after the weight loss, and those patients may need what's called a breast reduction, or reducing the size of the breast. But that's maybe about 10% of my patient population after weight loss.
Very good. Can you explain how these procedures are performed? Each of these?
Yeah, and basically every patient's different, and it really depends on the amount of excess skin one has to the amount of lift that you need. Some people have a little bit of drop of the breast. Some people have a lot of drop to the breast. Okay, so from the minimal lift is an incision that just goes around the areola, and I take out a little crescent area of skin and can lift the areola up, and I can lift the breast up. Then a little bit more, a more invasive procedure, a little bit bigger procedure, is an incision where I go around the areola, and then I make another incision around that, and I excise the skin between those two circles, and then I join them. So the joining of that, the incision, just goes around the areola, but what I excise is in the shape of a donut. So a lot of people call it a donut mastopexy or a donut breast lift. It brings up the breast like a purse string or like a cone. Sometimes patients can get by with that type of lift. A little bit more aggressive lift, or a little bit more of a lift that patients may need, incision goes around the areola and then down the front of the breast. Most people call that a lollipop lift. Incision goes around the areola and down the front of the breast, and we can get a breast lift on top of that. But most of my patients need what's called a full lift, which is an incision that goes around the areola, down the front of the breast, and then underneath the breast. Some people call it an anchor, an inverted T, or a Y's incision after Dr. Wise in Texas. And with each one of those procedures, an implant can be placed at the beginning of the procedure. So implant's placed, then we do the lift, whether it's a crescent, a donut, a lollipop, or the most common one, which is the anchor incision. It's extremely rare that I have to take the nipple off and put it back as a skin graft. Usually you can do all these lifts just with sliding or moving the areola around. That preserves usually nipple sensation and usually a good blood supply to the nipple.
Oh, well, that's wonderful. I'd probably need the anchor. That's
And yeah, that's the most common because my patients usually need a lot of lift breast after their weight loss.
Yeah.
Well, Jennifer, just to chime in, Dr. Katzen did perform my breast augmentation and lift, and I did have the anchor. So just to give you an example, and losing 195 pounds, I needed a lot of, what did you call that? I call it backfill, but
Yeah, you need to, with that amount of weight loss, you need to fill the breast with an implant in that case, and then also redrape the skin around it so you get a nice shape to the breast.
There you go. Okay, because our breast tissue is different than someone who has not experienced major weight loss, are there any other additional factors that we have to take into consideration when choosing between silicone and saline implants?
There are a couple of questions within that question. Weight loss patients' skin is very different than patients who have not lost a lot of weight loss. Weight loss patients, the skin is much more elastic, and I think you have to be more aggressive with your breast lift, making sure the skin is under sufficient tension to get the lift that you want. So if I have a patient that is non-weight loss and I do a lift under tension of, say, 8, and I do a weight loss patient under a tension of 8, the weight loss patient's skin is going to stretch out a lot more. So what I mean to say is weight loss patients need a tighter closure and sort of a more aggressive lift than somebody who is non-weight loss. And in terms of looking at the silicone versus saline, versus weight loss, non-weight loss, I think it's about the same. So I am a very big proponent of these silicone implants. I think they are very safe, maybe as safe as the saline implants, and I think they give a better result in terms of feel, texture, and complication rate. So most of my patients have the silicone implants, and I think they do much better with those than the saline implants. But if you're a weight loss patient, it's not much different than a non-weight loss patient in choosing between silicone and saline. Yeah.
Patty, do you mind me asking if you had silicone or saline?
I had silicone, 500 cc's. Usually people want to know the size too.
And do you feel like they feel more natural?
They feel very natural now. It took a little bit of getting used to, just because the difference of having, basically empty skin and then again having not just the implants but also the lift. It was weird, funny to have my arms again touch, something, my breasts and things like, just the things you don't think about, and so it was just a little bit of getting used to, but like anything else, it becomes your new normal.
So, Dr. Katzen, are there any complications with the skin if it has stretch marks?
Good question. No, there are a variety of theories as to why stretch marks occur, but basically it's the thinning of the dermis, the thinning of the skin. Sometimes you can get pigment changes within the skin. But if I see stretch marks on the breast, we sort of ignore them, and we just do our regular landmarks for a breast lift and breast augmentation. So stretch marks really don't tell us one way or the other you're a good candidate or a bad candidate for a breast lift. We just sort of ignore them and just sort of go about our normal breast lift pattern.
Okay.
Do people ever get a lift who've had weight loss surgery and not get implants with their lift?
Sure, absolutely. Some patients after their weight loss have sufficient breast tissue. Maybe they were a triple D, or maybe they're an F or a K before their weight loss, and after their weight loss, their breast maybe was a double D or maybe a D, and they're happy with the size, they just want the shape back. So leaving that size, a D or a double D or a C or whatever they want, I can do the lift on top of the remaining breast tissue and lift the breast up and keep what remaining tissue they have. But a lot of my patients have lost a lot of weight, and they lose a lot of that breast tissue. So much so that if even I preserved all the breast tissue, did the lift, they wouldn't have much breast shape just because the foundation, the breast fat, is all gone and melted away with weight loss.
Does the original shape of the breast and location of the nipples matter in choosing size and placement when getting a breast augmentation?
Yes, it does. But that really becomes very technical as to what you specifically have on physical examination. The size implant you decide, the shape implant you decide, and the look you're looking for. So if a patient came in and say they'd lost 200 pounds and they wanted to be a triple D, depending on the patient's anatomy, you'd probably have to go with a larger implant. And you'd need to make sure that the base of the breast can accommodate that size, and we rotate the nipple on top of it. So that's a really difficult question to answer without seeing a patient with physical examination. Yeah. So you really got to individualize that. So the type of lift is dependent on the amount of excess skin we have and the type of look you're looking for. And the type of lift is also determinant upon the size implant you choose. If you choose a little implant to maybe get you out to a B or a C, then maybe we have to do more lifting. If you go with a larger implant, usually we have to do less of a lift. But that's just big generalizations.
And how common are problems with breastfeeding after implants or just a lift? The person who's asking this is wondering if she should wait to have her surgery after she's had children.
Yeah. So this goes back to where the milk ducts on the areola. With the areola and the milk ducts, there are about 20 to 25 milk ducts that come up to the areola to express milk. So it's very unlikely, even with a full anchor inverted T breast lift, that all those milk ducts are cut. So there's a very good chance, 80, 90% chance that you'll be able to breastfeed after a breast lift, even with implants that are placed underneath the muscle. So, if breastfeeding is a very important concern of yours, when you have children, I would suggest, if you wish, maybe delay the breast lift and the augmentation till you're breastfed, and then come back and have the breast surgery. Because after you breastfeed and you stop breastfeeding, the breast does change shape. So you'd hate to spend a fortune and the recovery and pain and time off work, and then maybe a year or 2 years later have a child, and then the breast change again, and you need the surgery when the breasts have stopped changing too much.
Mm-hmm. Interesting. Okay. I think you kind of answered this already, but I'll ask, how do the different procedures affect the areola? Is removal and relocation necessary for both lifts and reduction?
Usually the areola needs to be rearranged, whether we're doing a lift or a reduction. Usually it's rare that the breast needs a lift and the areola is in perfect condition, perfect position. So we usually need to relocate the areola. That's sort of the main focus of the, when the eye looks at the breast, that's usually the area that we target. So when you're doing your breast lift, you usually create the shape of the foundation of the breast, and then at the conclusion, you put the areola on the top of the breast right in the middle. That's the ideal position. So usually with a breast reduction or a breast lift, you have to relocate the nipple.
Do you ever change the size of the, is it areola or areola?
Yes, it's the same. It's the same. So the nipple is in the middle,
okay,
and the areola is pigmented tissue that's around it.
Yes, like.
Yeah. Yeah.
Like what I'm trying to say is like. Okay, go ahead.
Yeah, usually, say 98% of the time, I do decrease the size of the areola.
Okay.
Okay. It is rare that I've had patients ask for the areola to be larger. Okay, rare. I've done a couple, but rare. By far the majority want the areola smaller. So usually within reason, I have the patients decide what size areola they want to have. But a lot of patients, I'd say 50%, say, Dr. Katzen, you choose on the table. And then we have special sizes of areolas that we use as templates in the operating room. And that has to do with size of the breast, look you're looking for, and sort of shape of the breast that you want as to the areola.
And how does that affect the sensitivity of the breast? Or is he frozen?
Uh-oh. Yep, I think he is.
He's frozen.
Okay.
So while we're waiting for him to come back, Patty, can you talk to us about the recovery from the breast augmentation, like what the length of the recovery was and how it went for you?
Sure. So thanks, Jennifer. So I had multiple procedures done at the same time, along with my breast augmentation and my breast lift. So it's hard to say exactly how long that recovery was specifically, because I also had the abdominoplasty with muscle repair, and I had liposuction of my legs and thighs. Now, the abdominoplasty was probably the more intensive, especially the muscle repair for as far as recovery goes. But I would say I was down for a week with all of them, where I was completely down, and then for about 3 weeks it was where I was resting the majority of the time, and then between 3 and 6 weeks. Each day I increased my activity, and by between week 6 and 7, I was back pretty much back to full speed. So that was the recovery. As far as pain goes, I would say I didn't really feel any pain at all in the breast region, but again, I had multiple regions going on at the same time. So the thing that was most painful for me was the muscle repair part.
Which was in your abdomen?
Yes. Yes, it was basically from your rib cage all the way down, to your belly button. They sew those muscles back together. So,
wow. So like your muscles are like this, and then they going straight down. They sew that back together.
Yeah. So they
separated,
right? and then they bring them back together.
Yeah. Which I know it can be common too with women who have babies. Like those muscles can separate and then need to be repaired after having babies.
Absolutely. It can even happen with working out or not inappropriately, but having wrong technique with working out. I understand people can damage their muscles.
Oh, welcome back. Yeah. Yes. Okay. Looks like he's back.
Hello.
Hi there. So going back to the areolas. Is there how is the sensitivity of the breast and the areola affected with surgery, or is it affected?
Usually the areola, I'd say 99% of the time, the sensation is intact. Okay. Very rarely do patients lose sensation. Some patients have maybe decreased sensation, but again, by far the minority. So usually sensation is intact after the lift, even with the augmentation. Some patients it's actually increased. Can't explain why, but I have maybe about 30% of my patients who say actually sensitivity is increased. I don't know why, just sometimes happens.
Okay. Good to know.
If you have large areolas that are maybe unusual shaped, oval, is it harder to make them look right with implants?
No. I would say if you are looking to be extremely large, triple D, larger, with implants, you can't reduce as much areola because the breast tissue is going to be stretched out, and it's even going to be tighter around the areola. But I mean, we can reduce the areola to the size of maybe a quarter, like the coin, that size, or maybe even smaller sometimes. Usually we don't reduce it that much. Usually reduce it maybe to a Eisenhower coin, if you've seen those, the dollar coins. Usually about 4 centimeters in diameter is what we roughly like to use. 4, maybe 5, sometimes 6 centimeters in diameter. So if you have a larger areola and you want to go smaller, but you want to go with a larger implant, it can still be reduced. So we can reduce almost any areolar size.
Interesting.
Before I go to the next question, I just want to let you know we have a couple people watching us live. Miss Beautiful Alicia is watching, and she's having the surgery that we're talking about, so she's very interested in what we're talking about today. And Kathy, or Sister Scaleback, is watching, and she has a question about the implants. She wants to know if there are risks of leakage from the implants.
Sure. There's always a risk of leakage from the saline or the silicone. Now, both implants have been studied for, let's see, 30, almost 50 years now. And you can be sure if there was any risk, the FDA would take them off the market right away. Okay? So in terms of safety, they're FDA approved for insertion into U.S. citizens. So, I mean, they couldn't be safer. Now, with a saline implant, if the saline implant ruptures, the saline goes into your system, your breast pocket absorbs that fluid, and the implant sort of deflates overnight, and you absorb all that fluid, usually overnight or sometimes within 48 hours. So the breast goes from 60 to 0 in about 24 to 48 hours. The silicone is a little bit different. When a silicone implant ruptures, the silicone is very cohesive. It sticks together. So if I took an implant and cut the implant, it would probably take about a year for that implant fluid to hit the floor because it's so cohesive. It's all stuck together. It's not the thought of, oh, you cut the implant of silicone and the silicone just goes all over your bloodstream. That does not happen. We've shown that in many, many studies, medical studies. So it doesn't cause brain tumors, leukemias, things like that. So silicone implants, I think, are very safe, and I think they are as safe as the saline implants. So I typically go with the silicone implants because they look, feel better, and I think statistics show that less capsular contracture rate than the salines.
Okay. Very good.
And is the side boob, like for lack of a better term, the side boob,
Yeah.
is that part of, like, is that removal part of the breast lift, or is that a separate surgery?
I usually include it in the same surgery. Now, when we say side boob, I think it's that area that overflows the top of the bra strap. Is that what
like
most
like
people
under
describe?
the armpit?
Yeah, yeah.
Do you want me to
So
show
there's a couple
you?
ways.
I'm just
So typically what I do is I will take the breast incision and take it around the side following the bra strap line. Okay?
Okay.
Sometimes I'll extend it onto the back to get rid of that side boob. Sometimes I'll bring the incision from the side of the breast. Remember that anchor, that upside down T?
Mm-hmm.
As that T approaches the side, then I do a 90-degree turn and then go straight to the armpit. Okay, and by doing that, I can excise like a football-shaped area of skin and fat from the side of the chest, and that'll get rid of the side boob. The nice thing about that incision is when your arms are down by your side, like all of us in this picture right now, that scar is hidden because your arm hides it. The one, if you take the incision and you take it onto the back, well, that can be a little bit more visible if you're wearing a low plunge line back dress. You sometimes can see that lower incision. But if you take the incision to the armpit, then that incision usually is hidden. So those are the two ways I do it. I term it the vertical torsoplasty. That's when we go straight to the armpit, or the horizontal, parallel with the floor, torsoplasty, where I extend that bra incision towards the back. So there are two types of torsoplasties for that, a side boob, as you call it.
Okay.
Yeah.
Very good. So you mentioned capsular contraction. What is that, first of all?
Okay. Capsular contracture is basically scar tissue that forms around the implant. So I'm going to try to flip my phone here. We'll see if it cooperates. 1, 2, 3. Did it work? No. I don't know why it keeps reading sideways. That's okay. All right. So capsular contracture, basically, whenever you have something that's not you in your body reacts to it and forms scar tissue. So if you have a splinter in your hand or your foot, your body's like, whoa, that's not me, and makes scar tissue around it. So by definition, that's a contracture. That's scar tissue around the implant, okay, or around a foreign body. Now, when you have implants in, your body is like, whoa, what is that? And makes scar tissue around it. And we've tried multiple different items and solutions as to minimize the scarring around an implant. And we've come up with, the state-of-the-art breast implants now, where they have a silicone wrapper to the implant. So, capsular contracture is scarring around the implant. Okay, and when you have scarring around a half a grapefruit, if you will, which is the shape of the implant, when you have capsular contracture or scarring around a half grapefruit, when it contracts, when you contract around a circle, you get these little ripples. So that rippling is what's called capsular contracture. Some patients, it's minimal. All patients get it to some extent. Some patients, it's minimal, where you don't even see it, you don't even feel it. Some patients, it's extreme, where you have to actually go in with surgery, take that scar tissue out, change out the implant, and put in a new implant. So it really depends on the patient, the implant that's used, the position that's used, and sort of their healing state. Yeah.
Interesting.
But good question.
How common are they? And is a revision, you kind of mentioned the revision, but is that necessary to treat the condition? Do they have to go under anesthesia again?
Oh, it really depends. Not all capsular contractures need surgery. I would say capsular contractures, they occur at different rates. They're more common with the saline implants than the silicone implants. And I think it's more surgeon dependent than really national statistics that really matter. I think if you go with a smaller implant, silicone that's placed underneath the muscle, I think you wind up with a much lower incidence of capsular contracture. If the capsular contracture is causing problems like pain, extreme discomfort, visual deformities, then you may want to think about having the capsular contracture operated upon, having that implant removed and the scar tissue around it removed. But if it's not causing any problems, I would leave alone.
Okay, very good. Oh, for Jennifer, she's having a coughing, so we're gonna go on to our next question. What other procedures can be combined with a breast lift and breast augmentation?
Sure. We talked about the side boob, if you will, the torsoplasty, that area on the side of the breast. But often I combine the arm lift with the breast lift at the same time. To me, it's sort of the same general area, and we do it under general anesthesia, and we're able to use the brachioplasty, the arm lift, or arm reduction more accurately, and the breast lift and the torsoplasty all at the same time. Sometimes the side boob, if you will, continues all the way on the back, to the point of I'll have to do that horizontal torsoplasty, that incision on the side of the chest, and I go around following the bra strap line. But sometimes that side boob or that back fat is so large that I have to make an incision that goes all the way around the back. So it pretty much follows the bra strap line all the way around the back. Some people call that an upper body lift or a upper 360 or a back lift. And sometimes I'll combine that also with the breast lift and or arm lift at the same time. So you wind up with that back lift, upper body lift, the breast lift, and the arm lift all at one surgery.
Okay. All right. Are there any other surgeries that can be combined with the breast lift or breast augmentation?
Sure. You can combine the tummy tuck with the breast lift, which is called a mommy makeover when we do the tummy and the breast. I often combine the breast lift with the leg lift sometimes. The only surgery that I would say I would not recommend doing the breast lift with is the buttock augmentation or fat transfer to the buttock. Reason being is you're going to be laying on your back to heal up from your breast, and when you're laying on your back, you're sitting on your buttock, and you can alter the position of that buttock implant or alter the position of the fat that's been transposed. So if you're thinking about doing breast augmentation, breast lift, and the fat transfer to the buttock or the implant to the buttock, you may want to think about staging those, doing those in two separate procedures. Otherwise, you can do a lot of breast procedures, a lot of other procedures with the breast lift.
Interesting. Okay, very good.
Okay,
I'm
so sorry. I'm so sorry, guys.
Are you okay?
Yeah, I'm so sorry.
Okay, it's okay.
I started coughing. I couldn't stop, but I think I'm okay now.
That's okay. Break away if you need to. It's all. I know you kind of answered this, but we've got a couple of questions. So, saline or silicone, under or above the muscle, and what are your preferences for the best results?
Sure. I think the best results in my hands are silicone implants that are placed somewhat under the muscle. Now, there's a long history of what to do with the implant. When we first started doing breast implants, 1970s, early 80s, people were putting the implant completely underneath the pectoralis muscle and then covering it with some muscle from the back. So the implant was 100% covered. Then there was a wave of, we're going to put the implant on top of the muscle. And now there was a wave back towards putting the implant half under the muscle and half over the muscle, called a split muscle technique. And I really think that's the best. So the upper half of the implant is covered by muscle, and the lower portion of the implant is free, not covered by muscle. So I think in my hands, the best result is a silicone implant placed half under the muscle, half over the muscle, and depending on what kind of lift you need at the same time. Yeah.
Very interesting. Okay, very good.
And how long will the breast implants last before needing to be replaced?
Good question. Very, very common question. I think most ethical plastic surgeons will say, you know, if it ain't broke, don't fix it. That means there's no real timeline on it. It doesn't say, okay, every 7 years you got to come back and I'll see you every 7 years from now till the end, and we'll keep replacing the implants. I think most ethical surgeons will say, if you're not having any problems, if you're not having any pain, capsular contracture, deformity, you don't want any corrections, you don't want the implants larger or smaller, leave well enough alone. So just leave the implants alone. So there's no timeline on it. There's no, it's not like wheels on a car where, you know, every 10,000 miles you got to replace them. It doesn't work like that. The implants are sort of, they're built for a lifetime, but statistics show that in your lifetime you may need one revision for one reason or another. Usually it's not a fault of the implant, but it's usually of, you know, I want to go with bigger implants, or, you know, I want a little bit more of a lift, or, you know, I'm sick of this size implants, I want to go a little bit smaller. So that's really not a defect of the implant. That's more of a personal patient choice. Yeah.
Very good. You just mentioned revision. What are some of the reasons a patient would want or would need a revision?
Yeah. Sometimes with weight loss patients, the skin is very elastic. And sometimes we get, you know, great results on the table and it looks fantastic. And then sometimes 2 or 3 years later, a lot of it is sagging and it may need a revision. That's to do with the nature of the skin, weight loss patients being very elastic, and you may need a touch-up revision at that time due to the nature of the skin. So sometimes touch-up mastopexies are needed. Sometimes that can be done in the office. Sometimes we have to go back to the operating room. It just sort of depends. Some patients want to go larger. Some patients want to go smaller. In my patient population of weight loss patients, most patients have been big in their breast area for their whole lives, and they really don't want to go back there. So they usually go on the more conservative side, maybe B, C, maybe a small D. But it depends on the patient too.
Interesting.
In my practice, it's all about proportions. You know, and that's the reason why I do the breast after the tummy tuck or the body lift, because we'll get the tummy looking so flat, and the breast may be disproportionately big if you choose implants before your tummy tuck or body lift.
Very good. Do you find combining certain procedures puts a patient at a heightened risk for needing a revision?
No. Good question. But I don't think combined procedures increase your risk of revisions. No.
Okay.
No.
And are revisions, you answered that. You said sometimes they're done in the office and sometimes they're done in the operating. Yeah. Okay.
Yeah, it really depends what is needed. If it's a little nip tuck, if you will, then we can do it in the office. But if it's, you know, requires, we got to revise the whole T incision, got to change out the implants, capsular contracture, we're going to, of course, do that in the operating room.
Okay, very good.
And what is the process to determine breast implant size?
There are 101 different ways. Okay. Some, you know, very good friends of mine, plastic surgeons, board certified plastic surgeons, you'll come to the office, we'll take digital pictures, and we'll do it on a computer screen. Okay. Very good friends of mine, plastic surgeons in Florida, they'll have you lay down and they will size you in a gel mold and then figure out the volume by putting water in the mold that you lay down and the size you want. Other people will do it with rice sizers. So there are a million and one ways to do it. Now, what I do is I had the patient come to my office. I don't tell them at all what CCs we're looking at. I just tell them to try on the implants in front of a mirror and tell me if they want to go larger, larger, larger. And we have a series of implants. We probably have about maybe 200 implants in the office now in terms of sizes and shapes and looks. So the patient will keep trying on implants till they're like, oh yeah, that's good, a little bit bigger, and then they'll try an implant and they'll go, whoa, 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 that's too big. And we'll go, okay, that's the size, that looks proportionate to you. They'll look at themselves in the mirror, profile, forward. A lot of friends, sometimes a family will come with them to get a better visual. Sometimes I'll let patients go home with the implants so they can try them on with different clothing at home with the implants. And then we decide on that implant size. So once they go for the look, then I take out the implant from them in front of the mirror and go, oh, you chose a 500 cc implant. So that's the implant we go with. So I go with what the patient is looking more for than numbers on a computer screen or measurements we do in the office.
Okay.
I know from my own experience what was really interesting, because I had the abdominoplasty with the muscle repair, and so the projection of the breast implants, because my stomach's being pulled back now, your breasts stick out more, project more, I should say. So it was a good experience, because I didn't even think about that, but of course you guided me along that to understand what would happen once my tummy was pulled back. So
it's good. It's good.
Yeah. Okay, we keep hearing about spitting stitches. What does that mean?
Spitting stitches?
Yes.
Yeah. It can be a variety. Spitting stitches basically means that the stitches are coming out of the wound. So it can be that your body is rejecting those stitches, like your body doesn't like them and they're trying to get rid of them. So it spits them, it brings them to the surface and gets rid of them. Sometimes there can be an infection and the suture can get infected, so the body rejects that suture and spits it out of the body. So those are the most common reasons for spitting sutures. Yeah.
Are those surface stitches, or are those usually surface stitches, or way inside?
They're usually deeper inside. The sutures that are closer to the skin usually are much smaller, and then as we go deeper, we use bigger sutures. And it's usually those deeper sutures that the body doesn't like that it's trying to spit out.
Interesting.
Yeah.
What is the recovery time following a lift or augmentation?
Yeah, everyone's a little bit different, but I usually say for a straight lift and augmentation, it's about a week to 10 days. If you have a desk job, I think you can return to work usually in about 10 days to 2 weeks. If you have a more physical job where you do a lot of lifting and moving boxes and things like that, perhaps maybe take off 2 to 3 weeks. Anything that really affects the pectoralis muscles, that's where you have to take a little bit more time off from work. But if you're just doing maybe data entry, answering phones, I would say maybe 10 days, 2 weeks.
Wow. That's much faster than I would have thought.
Yeah, now everyone's different. Some patients are, able to go back after about a week. Some patients are, not able to go back after, 6, 8, 10 weeks. Everyone's a little different.
Okay.
Everyone's a little different. But in terms of, the technique and the surgical profile and the way we do it, most patients are able to go back to work at about 2 weeks.
And that's just with the breast lift and breast augmentation, but if you're having more surgeries, does that impact the time?
Yes. Absolutely. I mean, if you're doing an arm lift and a leg lift and tummy tuck at the same time, sure, it's going to make your recovery a little bit longer. Yeah.
Very good. Dr. Katzen, can you explain what types of garments are worn post-op?
Sure. For the breast lift, typically I have you in a very loose garment. The reason for that is I don't want anything too constrictive on the chest, and I leave that loose garment. It's sort of like an ACE bandage, but not as tight as an ACE bandage. And that goes on the chest loosely to keep the bandages in place and minimize the swelling. Then usually at about 3 to 5 days later, I'll take that dressing off and then put you in a sports bra. The nice thing about the sports bra, it provides support. It minimizes swelling. and it makes the patient feel a little bit more comfortable and more in control. And then depending on the patient, I'll have you wear that sports bra for anywhere between 4 to 6 weeks to minimize swelling, help keep the scar flat, and to just make the healing just much better.
Okay, very good. What types of bras should a patient have on hand for their post-op care?
So I typically, for my patients, I will provide you with a medical grade sports bra. It's got the clasps in the front and Velcro on the shoulder. That means it's very adjustable, and you can very easily personalize the bra as the swelling goes down. Because as the swelling goes down, if you have just a standard bra, the compression will get less and less with the swelling going down. So with this surgical bra, you can tighten it as the swelling goes down, both on the shoulders and between the breast. Then after you've healed up from that, or maybe you're wearing my medical grade one, you can transition also into a sports bra, but ideally if you can get the sports bras that have the clasps in the front. Okay. Yeah.
And then how long is it until a regular bra, maybe with wires or not, under wire, can be worn again?
Yeah, typically at about 6 to 8 weeks, I'll let you wear the regular bra. Typically, if you have sensation, and 99% of my patients do, where we can allow you to go back to a wire bra. The reason we don't have you wear a wire bra initially is you may have some areas that are numb, and that numbness with a wire bra can lead to some irritation and, in fact, some skin breakdown too. So we don't like under wires initially at first. Also, sometimes the wire bra can dig into the incision.
Interesting. Okay. And as far as the long term, would you recommend sleeping in a bra to maintain a better long-term result, or does that matter?
Yes. I think the more support you can give the breast, the better the results are going to be. So if you can wear a sports bra, for a good, I'd say 4 to 6 months after the breast lift, the more you wear it, the better. If you can sleep in it, even better.
Okay. Good.
And I know this is a question from Elizabeth, and she said she's asked you this before every time you're on, but she thinks it's important, and she wants, we get new viewers every week. So can you give us your basic recommendations on how to choose a plastic surgeon?
Sure. I think it's very important. I think probably the most important thing is when you're looking for a plastic surgeon, your plastic surgeon should be board certified. Okay, not only just board certified, but board certified in plastic surgery. I mean, most doctors out there practicing are board certified, but not all people that are practicing plastic surgery are board certified in plastic surgery. So I think probably the easiest thing to do, go to a website called plasticsurgery.org. Okay, it's made by the American Board of Plastic Surgery, and they will tell you if your plastic surgeon is certified by the American Board of Plastic Surgery. The #1 organization that is certified by the Medical Board of Subspecialties. Okay. So, 1, make sure they're board certified. 2, make sure they've done a lot of weight loss patients. Okay, what is a lot? I would say my rule is 50. Okay, that means they should be able to show you 50 weight loss patients of the procedure you're looking for before and after pictures. Not, I'm going to email those to you. Let me look for those and get back to you. They should be able to write on a website 50 weight loss patients of the, say, breast lift or breast augmentation you're looking for. They can't do it. They may not have the experience to be doing those procedures. That doesn't mean they can't do it, but you should look for somebody with a significant amount of experience.
Okay, very good. So we know you're going to Nashville, Dr. Katzen, for the WFA. We're so excited. In addition to phone and Skype consultations that you do for people who are not local, can you let people know how to get in touch with you the best way?
Yeah, sure. You can just jump onto the internet, and my first name, Timothy, Timothy, Katzen, Katzen, MD.com, and then you'll be guided to my website, and then you can contact us there by email, by Twitter, Snapchat now, Facebook, everything. In the fashion one. So yeah, just to log on to our website, and then I'll be happy to answer any of your questions.
And where are you located?
Sure. We're in Beverly Hills, and I also have an office in Las Vegas too.
Oh, oh, that's awesome.
Yeah.
Do you have a lot of patients from out of town who come
Yeah.
to you?
About 40% of my practice comes from outside California, and of that patient population, I would say about 40% of those patients that come from out of state come from overseas. So we have a lot of patients from the Middle East, a lot of patients from Australia, a lot of patients from Canada. So we get them from all over the place. So.
And how often are you in Las Vegas?
I'm in Las Vegas about every 2 weeks. Is
Oh,
what we're planning for now. Yeah.
I think I saw you're going to be there this weekend, this Saturday.
Yep.
Right?
I'll be there this Saturday if anybody wants to come out. I'm seeing a whole bunch of patients, so I'll be happy to see more patients too. Yeah.
Very good. Did we get any more questions, Jennifer, online?
No, but we did get a comment from Kathy, Sister Scaleback. She saw you on My 600-Pound Life. Where are they now? With, she says, is it Jalyn? Jalyn.
Yes.
And she just wanted to say that you were fantastic, that you are very down to earth and very personable.
Oh, well, thank you very much. Well, thank you. Yep. It was a very good show. I think it went over very well, and very proud of her and everything she's been through, and can't wait to see her in Nashville.
Yeah. Well, that was amazing results, Dr. Katzen, on Jalyn and everyone that we get to see. So it was a great, great show. It was exciting to see the best be out there, and Jalyn's life is totally, changed and impacted for the better. So that was just really, really awesome. And it's a great thing that you do to donate your time, and also WSFA. Just the combination is so giving and really nice.
Sure, my pleasure.
And thank you so much for coming on the show tonight. You answered so many questions that a lot of us in the community would not have answers to otherwise. This is a very valuable opportunity for us, so thank you so much for doing that.
Sure, my pleasure. My pleasure.
Okay, our next show will be this Sunday, and Elizabeth will be back with Lauren Dayton, so that will be exciting. Patty, do you know who's co-hosting that day?
I believe it's Lindsay Sly.
Okay. I think you're right. Okay. So please check us out on Sunday, 5 p.m. That would be Pacific Standard Time. And thanks so much for watching. Any final words, Dr. Katzen?
No, I just hope a lot of people can come out to see us in Nashville. It should be a lot of fun. And just keep on watching Naked Truth.
Yeah.
Thank you. Thank you. Please remember to like and subscribe, and we'll see you on Sunday.
All right. Thank you so much, everyone. Bye-bye.
Thank you.